Well, I'm Dr. Vinod Kumar. I'll be speaking today and giving a presentation about one of the methods to reduce the disease and treatment burden uh, of diabetes in elderly patients. So I will just try to uh, share my screen first. Just a minute. So I hope you can see these slides, and I'll just put them on slideshow now. Here we go. So the subject is mitigating the diabetes burden by enhancing the intrinsic capacity of elderly persons. This subject is probably of public health importance at the village level, at the peripheral and grassroots level. I think the emerging concepts in diabetes care for elderly is there are two concepts that I would like to present today. One is managing the functional declines of old age, which are collectively termed by World Health Organization as intrinsic capacity of elderly. This is to improve the diabetic care. Secondly, social prescribing is to connect elderly diabetic patients to non-medical social activities as it is also useful in diabetes care. So I would be talking about these two concepts somewhat in brief. World Health Organization recognizes following functions which progressively decline with advancing age. These are both physical and mental functions. First is cognition, which is concerned with our memory, thoughts, comprehension, and so on. Second is vitality, for which the key resource is our nutrition. Third is mobility, that is our walking, our day to day working with physical movement and so on. Next is sensory function, which comprise of mainly two, the vision and hearing. And last is our psychology. So in old age, these five or six functions have been recognized as of paramount importance by World Organization, and by addressing these functions, one can do better as far as his diseases are concerned in old age. This how it is of interest to diabetologists. You see, diabetes has a bi-directional relationship with intrinsic capacity, and which I have already said, which includes the various physical and mental abilities of old age. By this I mean diabetes promotes and accelerates the decline of these functions, while these declining functions increase the risk of diabetes them by themselves, and they also interfere with diabetes control in elderly due to a variety of following methods. One is failure to identify own medicine. Sometimes the elderly people take medicine at wrong times and doses because of problem of comprehension, decision, and memory. They may confuse meal timings and the contents of what they are eating. They may remain uh, not hydrated well. So if once they don't remain hydrated, they are susceptible to hyperglycemia and even dehydration. There may be failure to calculate the insulin dose correctly by these people. They may have been unaware of hypoglycemic symptoms due to mainly uh, compromised psychomotor ability. They are unable to exercise properly, and that can make them vulnerable to sarcopenia and frailty. And very often, they may be, not very often, but somewhat often, they can be non compliant to medical advice. And other social factors like isolation and loneliness also interfere with diabetes care in these people. So, how frequent is the intrinsic capacity decline or the decline of these physical and mental abilities in old age among diabetics, versus non-diabetic elderly. I think this is highly variable. Some diabetics may have good abilities, while some non-diabetics may be having rapidly declining abilities and vice versa. So this is a highly variable kind of thing. And this variability is mainly due to differences in age. The older you are, the more disability you are likely to have. Then gender, the women are little more susceptible to these disabilities compared to men. How lifestyle factors have been followed in your life? What is the socio-economic status? What is the magnitude of accompanying comorbidities and how magnitude is of geriatric syndromes in your persona? Among diabetics, particularly duration and control of diabetes and insulin usage have been found to determine the prevalence of intrinsic capacity decline. The longer the duration of diabetes, the more is the decline of intrinsic capacity. Further observations in relation to diabetes have been made by various authors. Lower intrinsic capacity scores have been associated with higher glycemia and incident appearance of type 2 diabetes risk. Intrinsic capacity screening, if you screen all your elderly people, including those diabetics, this helps evaluate frail elderly diabetics rapidly and they are able to minimize the disease and treatment burden. So it is important to know what is the IC screening load in a given individual, particularly who is a frail elderly diabetic. Stratifying the elderly diabetes based on both the score of resulting from IC screening and from comprehensive geriatric assessment, which is carried out in some patients for geriatric syndrome, this helps setting the correct glycemic target. Thus, better diabetic control among elderly by improving their intrinsic capacity and managing the geriatric syndrome is a distinct possibility. So, improvement in elderly diabetic care therefore requires screening, prevention, and management of intrinsic capacity decline by primary, secondary, and tertiary actions. There we require co-linkages between treating physician, geriatrician, and a trained multi-purpose health worker for assistance to the physician to screen and address basic issues by spending the required time with the elderly diabetic patient since the treating physician may not have that much of time. So how do we screen intrinsic capacity and how do we assess them further if necessary? Screening can be quickly done in about 8 to 10 minutes by a tool called Integrated Care of Older Persons, ICOP tool of WHO. This can be done by community health worker, and if a detailed assessment is further required, it is done by healthcare professional. Now coming to the quick screening, these on the left side you are finding the various intrinsic capacity components. With regard to cognition testing, screening, you just have to ask the question about orientation of date and place and show them three objects. And after some time, ask what is the name of this subject, these objects by recall. And we will find whether he is able to recall, he is able to give the correct date and place where he is. For mobility, it is just you ask the subject to sit on a chair without armrest, with his arms crossed in front of chest, and ask him to stand and sit again on the chair, stand and sit again on the chair. If he is able to do these 5 chair rise tests in a matter of 14 seconds or less, it's okay. For nutrition, you just ask simple question. Have you lost more than 3 kilogram weight in the last 3 months? Or has your appetite gone down? If any of these questions is positive, he is scored yes. For vision, you ask question whether he can see properly. You have to test for his distant and near vision and whether he has got hypertension and diabetes because both can damage the eyesight. So if any of these things is present, the score is positive. For hearing, you carry out a whispering test and sometimes screening audiometry. The score is positive if it is positive. Psychology, just ask the question, are you feeling depressed sometime during the last 2 weeks? And whether you feel have you feeling disinterested in surroundings during the last 2 weeks? If it is there, it is a positive thing. If any of these things is present, then the trained healthcare professional can further go on. For example, for cognition, he can carry out MMSE or mini-cog or MSCA test. For chair rise test, if it is positive, he can test the gait speed, the balance, and if he has the problem of nutrition, he can undergo mini nutrition assessment. Similarly, for vision, visual impairment, eye disease can be checked by the ophthalmologist. For hearing, risk factors, pain and discharge by an ENT expert. And for psychology, if more questions are needed to find actual depression is there or only there are symptom depression and necessary psychological referral. So there is a video also available for this screening process, and the link is given below. So, what are the primary actions that one can take in case any of these six domains are positive? If for cognition, primary action is cognitive stimulation. For mobility, multimodal exercises. I will be dealing with them in little detail. Nutrition, dietary counseling advice, vision, ophthalmology referral, hearing, ENT referral, and depression psychological support. So, how do we prevent and manage impaired cognition? First is cognitive stimulation. If there is an impaired cognition, one has to subject the patient to cognitive stimulation by a variety of methods like self-brain challenging, there are plenty of them available, recollection exercises, or sensual stimulation. You have to stimulate in various senses like vision, hearing, cognition, etc. And you have to encourage social interaction for such an individual. Multimodal exercises like aerobic, resistance, balance, and stretching important. They are all good for brain health. And finally, the cognition impairment can also be addressed, if necessary, by managing conditions if they are accompanying, like malnutrition, polypharmacy, other intrinsic care functions, and general risk factors of dementia like obesity, hypertension, and dyslipidemia. With regard to preventing and managing the impaired mobility, which is the second intrinsic capacity component of an elderly individual, exercise and nutrition, again the same four kind of exercises including yoga, and give adequate amount of protein for muscles. Managing conditions at present like arthritis, sarcopenia, polypharmacy, and if there is any pain, it has to be addressed. Environment has to be managed. That means the house has to be elder friendly. House has to be adapted so that there are no loose fitting carpets, no slippery floors, no darkness in the house, because this can lead to fall in these patients. If necessary, some patients may need assisted devices like spectacles, hearing aids, or wheelchair, etc., or walker. There should be safe walking space outside the house also. And if necessary, one has to refer to the exercise specialist and rehabilitation specialist. Preventing and managing other declines. For nutrition, for vitality, diet counseling important, exercises are important for muscle and for giving nutrition, monitoring of weight, adequate dose of vitamin D, vitamin B12 if necessary, protein intake proper, and hydration is equally important. And psychologically, dining with the family, dining in social gathering is also important for good nutrition. And one has to treat, as I said earlier, sarcopenia and frailty, which may be aftermath of poor nutrition. Vision and hearing decline, again, house adaptation, same thing I have already said. Elder friendly house has to be there. Family and social interaction are important. Eye to eye contact is important. Not that all the family members are sitting in separate rooms, busy with their mobile, not interacting with each other. I think for elderly people, this interaction by the family is important, and the elderly person has to be encouraged and go out and interact socially with relatives and friends and whosoever he comes in contact. For hearing, noise exposure has to be avoided, otherwise, the hearing will go further down. For vision, if there is hypertension and diabetes in this patient, both have to be properly treated and controlled in order to arrest the further visual impairment. And whenever necessary, the specialists have to be taken into account for referral. For depression, there are a number of strategies. I will not go into the detail, but they include cognitive behavior therapy, problem solving therapy, behavioral activation, life review therapy, multimodal exercises are also important for depression. They are easy way to ward off depression, and various kinds of mindful practices, including meditation, focus, focusing, etc. Now, the second important emerging concept I had told you is social pathways to diabetes. And here I have already told you social prescribing implies referral of patient by the doctor to a link worker who helps the patient to access community services which are often non-medical. This is a concept which came from NHS of England, and I think in some countries this is now being formalized as it has been found to improve the diabetes control. Not only it results in health and well-being, generally it has general benefit for diabetics and can exert a mild but a positive impact on fasting and PP blood sugar as well as HbA1c, and it has been found by a number of workers. The references are given below. Some Indian medicals like Dr. Sanjay Kalra also recommend that social prescription should be explored as an integral part of diabetes care. However, a formalized system enabling elderly diabetics to connect with social activities is required in India. Examples of community and volunteering activities with which you can connect your elderly people, they are divided into two parts. Either they are from quoted by WHO sources or they can emanate from various other sources. WHO sources include activities in clubs, activities in various faith groups, attending daycare centers, engaging in sports, volunteering of whatever he wants. If required, he may even get himself into a paid employment. Excuse me. Pursue hobbies. They may work and learn. They may also believe in spiritual practices, or they may work for adult education and even tutoring. Other sources of such non-medical community activities include intergenerational activities, knitting, cooking, environmental cleaning, community gardening, tutoring, group walking, music, new reading, learning a new language, and engaging in games, puzzles, crosswords, etc. So, with that, I come to the end of this presentation. Thank you very much.